So I would like very much to thank the Professor Giovanni Succo, David, and all the friends of the Turin group. And this meeting is supported by the Head and Neck Brazilian Society that was founded in 1967. And I am André Guimarães, and Drs. Bárbara Gregio and the Professor Marcos Brasilino de Carvalho also belongs to the laryngology department. And it's a very, and we have a very nice support for the APM. It's medical, how can I say, Rogério?
Paulista Medical Association.
Yes, from the Paulista Medical Association that is support for the transmitting this meeting, okay? Professor Giovanni Succo is an old friend of our society. He's a very nice people and excellent head and neck surgeon, ENT, head and neck surgeon. Many times we ask him for any approach or meeting, he's always accept. Professor Giovanni Succo has many peer-reviewed papers published along the many. And he's also the member of the Italian Society, ENT, and the Society, Surgical Society in Oncology. And actually, he is the chairman of the Congress of the Hospital Candiolo in Turin. So it's a very nice pleasure to have you with our society in this morning in Brazil, Professor. Also, Dr. Helena Maldi, she has degree in medicine and surgery and belongs to the team of the Hospital Candiolo in Turin.
Bom dia.
Bom dia. We also have the pleasure to have Dr. David Balmativola, that he's specialist in pathology. Yes? Thank you, all of you, for attending this meeting. And we have for moderation of this meeting, Professor Rogério Dedivitz. It's a friend of you. Professor Succo knows him very well. He belongs to the Department of Head and Neck Surgery from the University of São Paulo. And he also participates of the post-graduation course of the University of São Paulo, and is the boss and the full professor of the Unimis and the Fundação Lusíada in Santos. Professor Rogério has many publications along his life, and especially dedicated to larynx diseases, malignant benign diseases, and rehabilitation. So it's a really great pleasure to have all of you in this morning. Thank you. Professor Succo, it's your time.
Thank you. Sharing the screen. Okay. Can you see the presentation?
Perfect.
Okay. Thank you very much, André. Thank you very much to all Brazilian colleagues. Rogério, brothers, authentical brothers. We are along this year. We have a particular feeling between our societies. For us, it's an honor to be with you, even if virtually. COVID-19 is a serious threat to any kind of in my opinion, this could be an occasion to share our experience in another way, but probably improving also our possibility to share the current practice. In fact, together with Andre, we've decided to focus our lecture on the laryngeal cancer World Cup, that in our experience is the key point to trying to obtain the correct knowledge of the case and of the patient to be treated. Therefore, okay. Therefore, in order to to show you the current practice, we have chosen, together with our colleague that I would like to introduce you, to choose the patient that will be treated next week on Monday. This is an ongoing process, and we would like to show you our process of study and workup of this patient and this tumor. Here we are, the 5 guys, a couple of surgeons, Dr. Succo and Dottoressa Crosetti, that is here with me, a dedicated radiologist, Dottoressa Ilaria Bertotto, that is here on my left, and the 2 pathologists, Dr. Davide Balmativola and Dr. Nera Lamaldi, that are connected in another place, but they are with us. They are not, of course, involved in the diagnostic process, but they are involved in the quality control of this process, meaning that this is an important step of the workup. To have a check, a final check by the pathologist demonstrating or not the correct staging of this tumor. We have named this talk the Circle of Knowledge. The Circle of Knowledge, where we have a lot of steps. The first step, in our opinion, is trying to know our patient. Of course, we have to know the anamnesis, the histories, the history of the patient, the facilities, the availability of caregiver, etc., etc. But today we have a lot of algorithms useful in the first step of the workup to have a good prediction, by example, of the exposure of the tumor during a direct microlaryngoscopy in order to check or not the feasibility of transoral laser surgery. This is an important paper published by the group led by Giorgio Peretti and Cesare Piazza. Another important aspect is the algorithm demonstrating or not the possibility to spare the larynx with chemored instead of total laryngectomy, the TOL score, published by the American colleague. And this is a simple but useful algorithm demonstrating or not the possibility to spare the larynx with the chemored instead of total laryngectomy. We have prepared and we are validating this algorithm, that is the so-called OPHL score, based on clinical aspect and historical aspect, demonstrating or not the possibility to carry out an OPHL safely or not. At the end of this algorithm that is computerized, we obtain for the patient 3 lights. Green light, go ahead. Yellow light, be aware, this case should be treated only by the most experienced surgeon of the group. And the red light, meaning that it is impossible, in our opinion, to carry out an OPHL because there are too many risks. This means patients should be informed about the risks that are very, very high. The second step is a clinical step focused on the assessment of the transgression or not of this magic. This concept of magic plane is a concept that goes beyond the TNM, in our opinion, for open partial horizontal laryngectomy, meaning that with TNM we have information related to the anatomy and sometimes to the function, but we need more information. And if we apply this anatomical and radiological concept of a plane drawn between the vocal process of the arytenoid and the thyroid lamina, dividing the anterior part of the larynx and the power urine of the larynx that are represented by the posterior paraglottic space, the cricoarytenoid unit, we have a tumor staying in front of or transgressing this plane. This matched with the functional aspect of the motion of the arytenoid give us information really important about the possible feasibility, technical feasibility with safety of OPHL or not. And this aspect should be checked during the workup, because as demonstrated by our results, this is a case in which we have a clear transgression of this plane and the tumor involves the posterior paraglottic space, but there is also a clear fixity of the arytenoid. This means that a case with the high probability to have extra laryngeal spread. And even if the tumor is inside the larynx, the behavior is similar to a T4A. In our study, we have demonstrated that when the tumor not transgresses this plane, the results are exceptional and repeatable. And there are results that are not esoteric today, but everywhere around the world, when a surgeon is a skilled surgeon in this type of surgery, means that these results are reachable. But when the tumor transgresses this and enter in another subcategories, the results are not so good. This means that the tumor has showed characteristic at risk to be treated by open partial laryngectomy. Therefore, in order to check clinically the aspect of transgression or not of the magic plane, we have to base our judgment on a couple of important steps. The first is the object-based endoscopy, and the second is the imaging. But the guided imaging, meaning that, as our colleague will show you, we consider the radiologist co-responsible with the surgeon in the current indication. And the current indication is the results of a co-responsibility between a good office-based endoscopy and also endoscopy narcosis and the imaging. Then Dottoressa Crosetti will show you the concept of the office-based endoscopy as we normally do everywhere.
Okay, first of all, it is important an accurate preparation of the patient, spray, lidocaine spray by mouth and by nasal fossa, inviting the patient to breathe. We put the patient in a semi-supine position, and okay? Because the tip of the endoscope is over the posterior wall of the, the tip of the endoscope is over the posterior wall of the oropharynx, not inside the larynx, and is directed toward the larynx. In this specific clinical case, we observe an infiltrating lesion of the so-called angular region of the supraglottic larynx. That means the region where the ventricular band meets the epiglottis. The lesion go down, reaching the ventricle, and but not the vocal cord. As you can see in this picture, there is no subglottic extension, and the base of tongue is free. In this position, it's also important to perform an evaluation of the hypopharynx, of the retrocrical region, and of the piriform sinus, carrying out the so-called trample maneuver. We put a cannula in the mouth of the patient and we invite him to blow into the cannula. The second operation close the cannula, and in this way it is possible the air inflates the piriform sinus and the retrocrical region. And in this case, there is no sign of involvement by the tumor. At the end of the process, we obtain information about functional parameters, the motility of the vocal cord and the motility of the arytenoid. Also in slow motion, as you can see in this movie. In this specific clinical case, the question that I have to put to my colleague, Dr. Ilaria, that is our dedicated radiologist, is there is impairment of the left vocal cord and of the left arytenoid. So I will ask her, according to you, there is a possible involvement of the posterior cricothyroid space of the cricoarytenoid unit, or the impairment of the vocal cord and of the arytenoids is caused by a weight effect of the disease? These are the questions to my radiologist. Okay, and now after this office-based endoscopy demonstrating impairment of motion of the left arytenoid and possible involvement of glottis, because it was not easy for us to check, because when we have a bulky tumor, you need to move the tumor to see very well the vocal cord. And in an office-based endoscopy, not always you can check this aspect. Then before going in the theater to carry out the direct microlaryngoscopy, we need imaging, because the imaging can focus our attention on details really important to decide, in this case, by example, if carry out a type 1 instead of type 2 OPHL, or use, by example, induction chemotherapy in order to reduce the tumor, the tumor mass, in order to check if the arytenoid could be returned mobile or not. But with this information, we are able to ask precise, to address precise question to our radiologist. Here we are, Ilaria.
Okay, just a few words before to move on to imaging. As you can see in these schemes, in the process of tumor spread, there are some prevailing development vectors, and especially in the initial phases of the tumor growth, the anatomical permeability of the site of the origin of the lesion, the presence and the conformation of submucosal compartments, and the ligamental and osteocartilaginous barriers affect the way in which the tumor grows, with the lines of strength and of weakness. So we the imaging is able to assess the submucosal tumor spread by the evaluation a snapshot of a specific moment of a dynamic process that is the natural history of the disease. We know that CT is the mainstay in the evaluation of laryngeal cancer submucosal spread, but MR is preferable when the tissue discrimination is crucial, and the MR intrinsic high contrast resolution provides a better discrimination of submucosal changes in the tissue, especially when we have to distinguish tumor from peritumoral inflammation, or we assess the abnormalities in the cartilage. Multiparametric imaging, what does it mean? It means that we have different sequences that we use to interrogate a tissue, and then by combining all this information, we can express our diagnostic judgment. Obviously, it is not all so easy, because MR is very challenging technique, and it is very important the cooperation of the patient. Well, here we have the complete checklist with the questions that our surgeon asked me in this specific case of an intermediate advanced lesion. Obviously, if the lesion is an early cancer, the questions will be different. For example, we will analyze the depth of invasion of the thyroarytenoid muscle, for example. So move on to imaging. Here we have a supraglottic lesion that origins at angular region, and we know that supraglottic neoplasia for longer time tends to grow within the submucosal spaces, so in preepiglottic space and superior paraglottic space, and only later they will tend to grow down into the underlying glottis. So in this specific case, I'm expecting that the lesion will grow anteriorly and caudally.
This is an important aspect. I have introduced the aspect of co-responsibility between the clinical and the radiologist, meaning that in a case like this, we can decide if resect or not the preepiglottic space. Of course, I have to know to read the imaging, because I would like to know directly if there is this spread inside the preepiglottic space, because it is important for me to resect or not the preepiglottic space. But the radiologist know our problem, and the radiologist suggests, in this case, please resect the preepiglottic space. Okay? This means that sharing the information between radiologists and pathologists, this means that the whole group is able to suggest something, and also to enlighten your attention in singular aspects that sometimes are details, but details really important to obtain a good radicality after partial laryngeal surgery. That, as demonstrated in the book signed by Rogerio, here the millimeter play the difference. Millimeter, not centimeters. Millimeter plays the difference.
Okay, so one of the questions has already had an answer. So what about the hyoid bone involvement? You can see here that the lesion involves the epiglottis at that level, and on the left side it is very near to the inner cortex of the hyoid bone, but we can't find any signs of invasion. For the preepiglottic space involvement, yes, there is a suspect here. What about the superior paraglottic space involvement? Well, if you compare the two sides, you can see here that on the left side, there is a replacement of the regular fat signal intensity by the tumor. So on both these images, you can see that the superior paraglottic space is involved. What about the piriform sinus? So towards the glottic level. What can we see? We have a diffuse alteration of the signal intensity on the left side, but the question is the same as the tumor? No, because as you can observe, especially on this second image, it is brighter than the tumor one. So I suppose that peritumoral edema is present here. It involves the true vocal cord, the inferior paraglottic space, and also beyond the magic plane to the so-called posterior paraglottic space. But I have no alteration on these diffusion weighted images that reflects the motion of the molecules in a tissue that are related to the cell density. Okay, what about cartilages? As you can see, the bottom of the lesion is just above the arytenoid, and it seems to have, it is very close to it, and it seems to have a weight effect on the cartilage that shows this alteration, probably mainly due to peritumoral edema. At that level, the lesion is very near to the inner cortex of the left lamina of the thyroid cartilage, but as you can see, the hypointensity is regular, while at that level, you can observe mild alteration of the medullary portion due to peritumoral to edema, and the cricoid is regular. What about cricoarytenoid unit involvement? I suppose that the cricoarytenoid joint is not involved, as you can see also on this functional imaging on diffusion. And what I can observe moving down towards the subglottis is that edema is also present at that level. Here we have the lateral cricoarytenoid muscle, and probably it could be one of the reasons of the impairment of the mobility. Okay, what about subglottic extension? You can also observe a thin thickening of the submucosal, but with an edematous aspect. I don't find any image referable to Delphian node. And what about the neck? As you can see on bilaterally on level 2, 3, you can see some enlarged lymph node and a smaller one at level 4. I performed ultrasonography and I saw at level 2 bilaterally some reactive lymph nodes. At level 3, as you can see, some enlarged hypoechoic oval lymph nodes are present, mostly with fat ileum. I suppose it could be considered as reactive, but we have to consider that even when we use CT or MR plus ultrasonography, we can have about 30% of the cases of incorrect staging, because we can overstage or understage the status of N. And the main limitation is due to the micrometastasis that obviously we aren't able to detect.
Okay. Now we have a lot of information, really precise. I obtained the information by office-based endoscopy by Erika, demonstrating that the tumor probably reaches, not involves, but reaches the level of glottis. Ilaria demonstrated that probably there is only edema in the vocal cord, not direct involvement by the tumor. But there is an important information, functional information, that is the impairment or fixity of the arytenoid, the left arytenoid, without involvement of cricoarytenoid joint. This means that we have an elephant over a chair. Probably the weight effect block the arytenoid, but this means, surgically speaking, that we have to resect the arytenoid. Then, of course, we have to complete our information during an intraoperative endoscopy and doing the biopsy in order to solve the last question. This is, in my opinion, another important aspect, helping the anesthesiologist to intubate the patient without bleeding, because bleeding is the enemy of surgeon in order to obtain correct information during direct macrolaryngoscopy. Therefore, we normally use the video laryngoscope, helping us to help the anesthesiologist putting the tube in correct position. Of course, we always use small tube, meaning 5.5, no more. I normally use the Lindholm laryngoscope to carry out the workup, the endoscopic workup. This is a large endoscope, the large laryngoscope. The tip of the laryngoscope is put in the vallecula, meaning without entering the larynx. In this way, the larynx is free. There is only the tube, the orotracheal tube inside, and this is particularly useful to obtain good images. And this is the image we obtained with 0-degree telescope, staying inside the laryngoscope. As you can see, this information are not simple to understand, because there is the tube. The tumor reaches the level of the tube, probably transgresses this plane. This means that we cannot obtain all the information we need. Of course, it's possible in this way to study. This is the tip of the suction tube moving the mucosa. We can study the retrocricoid area, the piriform sinus, etc., etc., as shown by the endoscopy done in office by Erika. The tumor reaches the level of the area epiglottic fold without exiting the larynx, but the tumor is really near here. And with the tube inside, the information we can reach on the possible involvement or not of the glottis is not correct in this way. Therefore, we can remove the tube, remove the orotracheal tube. Why? Because the patient is fixed in this position. We can reach really easily through the laryngoscope, and we can replace the tube through the laryngoscope, and will demonstrate you. In this way, the information are more correct, because we can see the larynx in a general overview and also in details, and demonstrating also the narrow respiratory space in this case. But the information we can reach in this way are more correct. I don't know if Rogerio is in accord with me, but without the tube, in this way, we can see every type of anatomical region. In this case, we put the dilator of the false cord, As demonstrated in this picture, we can see that the vocal cords are free, but as demonstrated by Ilaria, the tumor reaches a few millimeters, probably 1 millimeter over. This is a 45-year-old patient, is a young patient. This means that the possible radicality we can reach here is no more than 1 millimeter, is at risk. The subglottic area is normal, as well as the cricoid. As you can see, of course, we cannot stay with the possibility take a look in another with another optic. I would like to return and to demonstrate you another important detail. As here, if you have problem to take an overlook of the larynx, you can also put the telescope not inside the laryngoscope, but outside, meaning that the telescope, the tip of the telescope is below the laryngoscope. The tip of the laryngoscope is in the vallecula, but the tip of the telescope is near the posterior wall of the oropharynx, allowing us to have to collect good images. Okay. At the end, we can apply also the digital enhancement. This is similar to MBI in order, by example, here, that is the corniculate cartilage, to understand very well if there is a tumor overlapping the epiglottic fold and also reaching the mucosa of the piriform sinus. Of course, the limit of our resection, if we try to operate this patient by OPHL is here, because this arytenoid should be resected, by the right one should be maintained. And after all this process, we are ready. Finally, we are ready, after obtaining by the pathologist the results of biopsy, to discuss this case in the tumor board. In the tumor board, of course, there are the oncologist and the radiation therapist. And we normally go to the tumor board with our indication. Our indication at the end of this workup is, in this case, for an OPHL type 2B, meaning resecting the whole supraglottics and also the glottis in order to obtain safe margins. The patient is young, 45 years old. In this way, my indication was OPHL type 2B and left arytenoid, super selective netization bilateral, level 3 and level 2A, frozen section if positive, completion of the neck dissection on both sides. But of course, in the tumor board, we have to discuss also about the results of possible different options. But the results obtained in our tumor board, not overall in the world. I have to know if my results are similar to that obtained by Isabel Villaseca, Giorgio Peretti, Rogerio De Vitis, etc., etc. This is honesty in front of patient. This is the same as OPHL. And this is, these are the same for total laryngectomy and concomitant chemoradiation therapy. Normally, we discuss the case without the patient in front. Then, at the end of our decision, we speak about our statement with the patient. Sometimes the patient is not in accord with us and decide to change tumor board in order to obtain a second opinion. The patient is free, but this is our behavior. But this is another important aspect, that is some information to the patient about the possible function, meaning voice and meaning also swallowing, we can obtain with different types of partial and radical laryngeal. Important step of our circle of knowledge, the quality control of the process obtained on specimen. This means that, of course, all the cases studied by the pathologist are operated, of course, but we today are able to apply the same concept also in non-surgical patient, because in my opinion, as mentioned before, it's really important to apply the same honesty in the workup in patient going to surgery and patient going to non-surgical treatment. And then the pathology can show you their role. Davide or Elena?
Hello, everybody. I'm Dr. Samaldi, the surgical pathologist. Now we will approach the role of intraoperative examination of the margin. As you may know, we need to answer specific questions posed by the surgeon in minutes instead of hours or days. So we need to change the process in order to obtain the slides. With the frozen section, we basically substitute the paraffin with another embedding medium called OCT. Some of you may know that we need deep freezing in order to cut the section. Please, next. As you can see, we deep freeze the tissue in order to have the thin slides to put on under the microscope. Of course, this process may affect the quality with the artifacts due to the deep freezing. Please, next. The quality, next again, okay, is affected because there's the formation of some ice crystals due to the rapid freezing. In our institution, we use the PrestoSeal, as you can see on the up right. This machine allows a quick freeze at 40 Celsius below in order to avoid the formation of these needles. As you may compare, you know, the two slides, in the right, we have the normal slides we may obtain with classics technique. And on the left, we can see the section obtained with the PrestoSeal. In this case, we can be sure of our answer and do not have any artifacts. Also, it makes the answer really quickly. Okay, I want to state very clearly that also we do not have any problem in the margin sent by Professor Succo or Erika Crosetti done with the laser CO2.
Okay, so nice to meet you. I'm Davide Balmativola, the other pathologist, dedicated pathologist. No, please go to the, okay, thank you. So Professor Succo was talking about quality control, and for the pathologist, it is mandatory to talk about large sections, talking about quality control. So probably the majority of you, both surgeons, radiologists, and pathologists as well, know what a large section is, and you know all of the advantages that using large sections allows to produce from the pathological point of view. So this slide is to focus your attention on how the pathology lab produces the large sections. It all starts with the large cells block. As you can see on the left and on the right, large cells blocks are just like the normal cell blocks, just larger. And we can put inside these large blocks larger slides of human tissue, of histological tissue. Please go to the next slide. As you can see on the top, this is one of the way we cut the specimens. This is an OPHL. So you see the cross-sectioning from lateral sectioning. We can put an entire section inside the large cell block. Then we will Then we will go to the procedures to obtain the large section. You can see on the bottom on the right, a large cell block embedded in paraffin of a total laryngectomy section. And then on the right, the large section slide we obtained. And as you can see, it allows the pathology to make anatomical correlation that are great. So it's a really important tool to use both for the diagnostic purpose and for the comparison we can make with the radiological imaging. So the use of large sections in the head and neck pathology is really, really important for us. That's it. These are examples of large sections, as you can see, that allows us to evaluate tumors in relation with different anatomical structures, the cartilage. You see a radial section on the left, sagittal sections on the right. So we can decide to perform large sections to obtain a vision, an anatomical vision of the larynx that allows us to make all of the important evaluation that can be helpful then for the surgeon, for the radiologist, for the learning curve in general. And this is what we do every time with the Professor Succo equipe. So that's it.
Okay, every time we apply this approach in studying laryngeal cancer to be treated in our institute, every time. And in our opinion, every new treated case means improving of knowledge. Because as Ilaria stated, we have a picture of the dynamic process that is a natural history of this tumor. First of all, we have to know the natural history of tumor, meaning supraglottic tumor, median, paramedian, etc., has a different natural history. We have a picture, we freeze the case in a moment of this natural history, and we have to know in best way as possible the real extension of this dynamic process. Of course, if we add the follow-up, we improve our experience, meaning that we improve our experience because we have also the data of success or not deriving from our workup and also by our treatment. But to sum up, the workup, as in agreement with Andre, when we've chosen this topic, is the key point, trying to put the correct piece in the correct place in the puzzle of laryngeal cancer. Applying this approach, meaning the same surgeon, the same dedicated radiologist, the same pathologist, in our experience, the rate of uncorrected clinical workup is near 10–12%. Okay? There is a rate of near 10% that we have a uncorrected clinical staging, comparing the clinical stage and meaning overstaging, not also understaging. All efforts should be made to prevent non-radical treatment, of course. This means that our treatment should help to correct the uncorrect stage, meaning that, by example, with the OPHL, we adopt normally a modular approach. And I'm really grateful to Rogerio and to Luis for the invitation, demonstrating our current practice in doing supratracheal and supratracheal laryngectomy, meaning that these are both ends of the same surgeon, meaning that we can, as we try to demonstrate, we can change our indication during the operation thanks to the information deriving from the direct assessment, but also the pathological assessment with frozen section on the real extension of the tumor. The current surgical techniques allow to modulate the resection intraoperatively to reach the complete radicality. In this way, as well as in transoral laser microsurgery and partial surgery of the larynx, not only horizontal but also vertical one. I know that Rogerio is a lover of vertical surgery of the larynx, but the concepts are the same. Yesterday I saw a perfect results of hemilaryngectomy. Good functional and pathological results, and in my opinion, not in my opinion, but our opinion, we have to put all our effort to improve and reduce the rate of uncorrect staging and uncorrect knowledge of the real extension of the tumor. Because for larynx, where millimeter makes the difference, this means okay, yes, of course, with the skill of surgeon and correct technique, surgical technique, means results or not in this fascinating but difficult field. Thank you very much. We are ready for your questions. We have prepared also clinical cases if you want to discuss some clinical cases with you. But now.
Thank you, Professor Succo. Thank you, Andrea, David, for nice presentation. I will open for questions of our colleagues that are viewing while you are preparing the case, okay? Please, if someone has some question, please put in the QSH.
Andrea, one comment.
Yes, please. Go ahead.
Gianni, congratulations for the perfect workup of such a case. One question, I think that type 2B is perfect for this case, maybe with arytenoid resection. But I was worried about the status of the interarytenoid area.
Yes.
In the previous analysis. What do you think about that? Is it
yes.
But
yes, as Rogerio of course is a skilled surgeon, therefore focus immediately the attention on the weak point of this case. And here we are. With the tube, we cannot check this area, okay? As you can see, with the tube, we cannot check this area. Therefore, we need to remove the tube and to check that in this area we have tissue free, but this is the right place to put the frozen section, because if you have a submucosal spread of tumor here, therefore for this reason this patient is informed that we can move from more extended surgery, meaning that, but this is really challenging, the possibility to resect also this part, meaning that not resecting all the cricoid, but resecting the rostrum, part of the rostrum of the cricoid, because there is the possibility to have a submucosal spread of tumor here. Here, in my opinion, is free. and also applying the MBI during the workup, and also, as you can see in the office-based endoscopy by Erika. Ok, dove è filmato Erika? As you can see, this is on the right, on the left side, but this mucosa seems normal.
Alô?
But is of course the weak point.
Quem é? Leonardo, eu tô no meio de uma reunião, meu amigo. Depois eu te ligo. Até lá.
Another possible weak point is the possible submucosal spread in the piriform synod, but all this mucosa will be resected, meaning that also the external surface of the larynx is resected with the left arytenoid. But as you can see, Rogerio, in my opinion, this mucosa is free. And also the margin is good because in my opinion, the tumor is here, but I can resect all this mucosa, meaning 3 millimeter and more. Of course, checking, we can reach this level, no more. We can reach this level, no more. But it's important the observation by Rogerio, because you have 90% of the situation under control, but 10% of situation not always under control. You have to be prepared how to do if you have tumor here. We can move, by example, to a type 3, resecting the rostrum of the cricoid. Because if you have a tumor here, we can resect the mucosa here, but the problem is the cartilage here. Therefore, we have to resect. Normally, today, we resect the rostrum of the cricoid cartilage by CO2 fiber laser, meaning that we can resect not the whole cricoid, hemicricoid, but only the superior part in order to have, at the end of the operation, a ring, a strong ring. Thank you, Rogerio, for your observation. That is really important.
Grazie mille.
Professor Succo, Professor Cernea has a question for you. Please.
Please. Ciao, Claudio.
Ciao, amico. I have actually 2 questions. Number one, this is actually congratulations by the presentation, by the way. I sent a message already. This is a patient with perhaps a supraglottic cancer slightly extending to the arytenoid. So, first question, would this patient be amenable to a robotic approach instead of purely transoral laser approach? First. Second question, because of this extension, would you include the level 6 lymph nodes as well in your elective neck dissection?
Okay, thank you very much, Claudio, for the question. In this case, we have, of course, considered also transoral robotic approach. Erika Crosetti is a skilled surgeon in this type of surgery, was together with the Professor Co for 2 months, a couple of months in the last autumn. Why not? I'm not sure that a type 1 supraglottic laryngectomy is sufficient for this patient, because the edema demonstrated by Ilaria at the level of the glottis suggest attention to this aspect. If I am sure that I have 2-3 millimeter, but safe millimeter over the glottis, I suggest in this case a transoral robotic approach. But when I have some alteration of signal at the level of the glottis, I prefer an open approach in order to check directly, and also moving to more extended radicality with the type 2B OPHL, because this patient is young. About level 6, good question. We have published a paper demonstrating that not only when we have a T4A, but also when we have a T3 involving the internal lamina of the thyroid cartilage, we have a rate of metastasis of the level 6 a couple of time more. Normally, our approach is doing the neck dissection, the superselected neck dissection at the side of the involved by the tumor, and during the dissection, the neck dissection on the contralateral side, we analyze these lymph nodes. If these lymph nodes are positive, of course, we complete the lateral neck dissection, but also doing the level 6, because we have to try the much more radicality as possible. Recently, we have a patient with N1. We have prepared the case during the gallery of clinical cases. This was N1, but was it 4 also? It was a small T4A. Our tumor board suggested post-operative radiation therapy, also informing the patient about the possible functional impairment of the larynx. The patient refused, and we had a metacron metastasis on level 6. Then we have to carry out a level 6 neck dissection. Therefore, considering the experience, this question done by Claudio Cernea allow me to stress the importance for head and neck surgeon to do thyroid surgery, because thyroid surgery is a good training to carry out the level 6 neck dissection. Because every time you have a papillary thyroid carcinoma, you are able to do this neck dissection, sparing the piriform, sparing the recurrent nerve. In this way, is not so important because we have to resect the retinoid. But in cases without resecting the retinoid, we can spare the recurrent nerves, sparing the parathyroid gland, but resecting all the lymph nodes. That is really important. The level 6, in my opinion, in big tumor like this and tumor with transglottic extension is an important weapon to reduce the recurrence that sometimes we don't know if this is a recurrence on T or N. Sometimes it's the same.
And Professor Succo, perhaps you must rise the salary of Erika, because she is already a microvascular reconstructive surgeon.
Yeah,
she's now a robotic
surgeon.
So next step, she's going to do chemotherapy and radiation therapy as well. So you better rise her salary as well.
For me, yes, because I'm going. I passed the 60s, and therefore, as a surgeon.
Speak with Mr. Agnelli to rise her salary, please.
Dr. Succo, so I suggest go on with the case for discussion?
Yes, of course.
Thank you.
Okay. Erica will show you the first.
We have the presence of our president of Head and Neck Society, Dr. Antonio Gonçalves. Thank you.
Hello, Antonio. How are you?
Fine. Nice to see you. Good presentation. Congratulations.
Thank you very much, Antonio. Nice to meet you. Virtually,
You have
but
to
we are
call him-
together. We are together.
You have to call him Toninho, not Antonio.
Okay, this is a good case demonstrating the challenging we have sometimes with patient in the selection of patient. Okay, Erica, please.
This was a case of female, 57 years old, in good performance status, and she arrived to our cabinet complaining sore throat. And in this case,
Excuse me. There is an important aspect. This is a good friend of my wife. Okay.
is a negative prognostic factor, tortoise. Okay. And in this case, the preoperative endoscopy was very difficult, despite an accurate preparation of the patient. First of all, because the oropharyngeal space was very narrow, and the patient was not so complete.
Erica, we cannot hear you.
Okay, sorry. You can hear now?
No, okay.
Okay, so there was a superficial lesion involving the right arepiglotic fold, the lingual aspect, and the laryngeal aspect of the epiglottis. Was very difficult until the midline. As I told you, the endoscopy was difficult, important gag reflex, but the motility of the vocal cord and of the areola was preserved bilaterally. Okay?
Okay, the radiologist.
The patient underwent MR, and as you can see here, there is an abnormal soft tissue thickening of the right free edge of the epiglottis. The lesion involves the laryngeal surface of the cartilage and the right ariepiglottic fold. And as you can see here, the tissue tends to extend beyond the midline, as Erica has just told us. So now we have to check the submucosal spread. As you can see here, the preepiglottic space is free from the disease, as well as the superior paraglottic spaces that are spared. We can't find any abnormal findings at the level of false vocal cord, nor the structures of the glottic plane. Here you can see the anterior commissure, the true vocal cord, inferior paraglottic spaces, and as well as the thyroid cartilages that the thyroid cartilage is regular, as well as the cricoid. And I don't find any enlarged neck node.
Okay, here we are the intraoperative endoscopy. Of course, we have checked during this maneuver the possibility to operate this patient by transoral approach because it's an N0. As you can see, we put the tube through the nose in order to check the exponentiality of the lesion, but as you can see, this was really challenging because this patient has bad opening of the mouth, small mandible, and narrow oropharynx, small larynx. This means that was a really challenging cases. The laryngo score was 5, meaning that was a difficult situation to manage transorally. Here we are, the therapeutic option. We entered the tumor board, and we would like to discuss with you about the possible indication. Rogerio,
Rogerio,
what do you think about?
I think that this kind of lesion would be would fit a transoral approach if the patient would have a good exposure. But with laryngo score 5, I'm not sure that transoral approach would be good. So I think that type 1 open partial horizontal laryngectomy would be a good indication. Type 1A. I think it could be a good indication. Since
Okay,
we have
also,
epiglottic space free, paraglottic space also.
yes, of
free.
course. Yes, of course.
I would indicate, since the exposure is not so good, type 1A.
Yes.
Regarding the neck, bilateral lateral neck dissection.
Yes. As was the same as proposed by our tumor board and by me in particular, because this is one of the best friend of my wife, 57 years old, and I suggested the type 1 PHL, but the patient refused. I don't want any scar in the neck. I'm not ready to suffer for therapy alone, done by tomotherapy, 60 grays on T and 56 grays on bilateral chain, lymph node chain. These are perfect results after 2 months. The tumor disappeared, but there was a prompt response to radiation therapy, meaning that also in a case when probably surgery could be considered the best option, after a good workup demonstrating not involvement of the paraglottic and the preepiglottic space, not involvement of the glottic plane, not involvement of the lymph node, we can apply the same approach, also non-surgical treatment, and probably with this policy sometimes we can reach a good results also not by surgery but non-surgical approach, but using the same policy, meaning the workup is important in the same way. Another case.
Can I make a comment on that?
Yes, of course.
I remember in the IFOS meeting in Korea some years ago. I was on a panel about laryngeal carcinomas, and a Turkish author showed a very interesting presentation on cases, laryngeal cancers amenable to laser resection with very poor exposure transorally. And he defended a very interesting point of view. I never used that, but just for the sake of discussion. He defended an open approach. I know this particular patient didn't want to have any visible scar in the neck, but when this was not the issue, so he defended an approach, an open approach, very limited one, exposing the larynx and then using the same technology, either laser, whatever, not transolary, but percutaneous. I never saw a publication on that, but I remember very well this particular presentation, and it was very ingenious. And he presented, I don't know, about a dozen cases. Have you used that, any one of you, or especially you, Gianni?
Claudio, as you know, probably because we have published also the movie on head and neck, we today perform all this type of surgery using the CO2 fiber laser. This is not the same, but really similar, meaning that the power is the same, and the particularity is that we don't touch the larynx. We resect without touching. This means that during a course organized by Giuseppe Rizzotto in Vittorio Veneto, I have operated a type 1 supraglottic laryngectomy extended to a retinoid. 2 days after surgery, this patient was able to drink, and Rizzotto played a video. 2 days after. But this means that it's very, very, very precise and very delicate procedure. This is important because reducing the power applied to the larynx, this means that the larynx is able to run immediately, because because Rizzotto made me a surprise in the next meeting 2 weeks after, demonstrating the patient operated by me 2 days and drinking after supraglottic laryngectomy extended to 1 retinoid. I was completely destroyed. This is a second case, another case important to demonstrate how how is possible to jump a stage from an early stage to a advanced stage.
Vocal cord.
I can't hear you.
Now you can hear me?
Yes.
A moment. The internet connection. Okay. Okay, so this patient arrived to our attention with an infiltrating lesion of the left vocal cord. This is the preoperative workup. It seems to be a simple T2, okay, of the left
41,
vocal cord.
41.
41A. And the motility of the vocal cord and of a retinoid are preserved. So seems to be a very early case. But you can see in this picture, it seems to have a small subglottic extension. You can see here, okay? So I asked to Ilaria a neck MRI.
Reaches
and the lesion reached the anterior commissure and seems to go a very, very small extension to the subglottic conus. Okay, so I asked to Ilaria neck MRI.
Okay, what about imaging? This MR image acquired at the level of the glottic plane demonstrates that we have left side laryngeal cancer that involves at full thickness the true vocal cord, and it spreads to the anterior commissure. Now focus your attention on this picture. You can see that all around the tumor there is a brighter alteration that is indicative of peritumoral edema that involves the posterior paraglottic space. The lesion anteriorly is near to the inner cortex of the thyroid cartilage that is regular here, while you can see this, this brighter alteration in the medullary due to edema. But please focus your attention on this linear alteration just outside the larynx. And now moving down towards the subglottis, on both the sagittal and axial images, you can observe this abnormal submucosal thickening that is suspect for tumoral involvement on the anterior aspect and on the left side. And at the same level, but outside the larynx here, you can observe similar alteration on even on morphological and after contrast media administration. And moving down, you can observe that it is clear now that an abnormal pathological tissue is present outside the larynx. And please focus your attention on this alteration at the level of cricothyroid membrane. The same findings, but please look at the cricoid. I don't find any alteration suggestive for invasion. Okay, I don't find the Delphian node, and on this image on coronal plane, you can observe that the posterior cricothyroid space is not involved, while the anterior cricothyroid space was involved by the lesion. And yes, and you on coronal plane. Okay.
Okay, with all this information, a case that could be considered an early case, no more than T2, considering that this is a cancer of the vocal cord reaching the anterior commissure, but with possible spreading in subglottic area, as this aspect. This is an information obtained by Erika. If you want to comment.
Yeah, we, as in the previous case, we remove the ventricle is free, is a vision with a 70-degree telescope, and the lesion is anterior in front of the arytenoid, and we remove the tube, sorry. We remove the orotracheal tube. We perform the evaluation with the 7-degree telescope, and you can see this swelling in the hypoglottis conus that is different on the left side from the right side. So
aspect of the cricoid ring, and in this way, if the clinical information, meaning that probably the tumor has a submucosal spread in the subglottic area and involving the conus elasticus and reaching the superior aspect of the cricoid ring, this means that a possible T2 is probably a T4 with the need, if we want to do an open approach by OPHL, to jump from a supracricoid to a supratracheal laryngectomy. Here we are the therapeutic option, starting by laser, and of course also discussing about the possibility to indicate radiation therapy, chemoradiation, also total laryngectomy, because this patient was 67, and with all this information, every type, in my opinion, every type of option are discussable, but correct. I don't know, you, what do you think about?
So, he's 67, but with a very good performance status. I would try to indicate a partial approach. I think that type 3A is fair enough, but you will kill me. But another option to think about is to perform hemilaryngectomy with extension to the subglottis. Since the cartilage is free, you can give a good margin in mucosa and the submucosal area of the subglottis, sorry. I think it could be considered as an option as well.
Yes,
but,
yes, of course.
3 is, I don't know.
Not considered only because the tumor reaches the anterior commissure. This means that you have to overlap a small part of the anterior commissure with the risk sometimes of stricture. Yes, but I agree with you. If you are a skilled surgeon in this type of surgery, that probably an extended hemilaryngectomy could be another option. In my experience, I believe to warranty better performance to my patient with an horizontal partial laryngectomy. But of course, if you are skilled in the vertical surgery of the larynx, I agree with you. We proposed a modular.
I knew Rogerio was itching to do a partial vertical laryngectomy. Sure about that. But as Toninho is watching us as well, we have a paper, a multi-institutional paper that we published a couple of years ago on supratracheal, on the results of the Brazilian experience. And this patient, I think, would be completely suitable for a supratracheal laryngectomy, provided, number one, chemoradiation is offered to him as well as an option. And number two, the patient must be informed that eventually, intraoperatively, even if we plan as a plan A to do a supratracheal, eventually, perhaps we have to extend to a total laryngectomy, and the patient must agree with that. I remember the second time I was in the Vittorio Veneto as a guest professor, visiting professor, operating there, I was participating in 2 cases of supratracheal, candidates to supratracheal laryngectomy. One was with you, Giovanni.
Yes,
and,
of course. Yes,
you remember that. And because of frozen sections, what appeared to be a patient suitable for a supratracheal, actually, we had to undergo a total laryngectomy. So the patient must be very aware about that.
Sorry, Jenny, your video stopped.
Obtained a former concept about possible shifting to total laryngectomy every time.
I would like to do a quick question. In Brazil, usually, when we offer open partial laryngectomy and or chemoradiotherapy, most of the patients, of course, it sounds better, it sounds less aggressive, no surgical treatment. So it's very difficult to do a good opinion for the patient. If the decision of the patient, most of the cases are for not surgical treatment. How do you manage this case in Italian?
Yes, this cultural influence is true, because, by example, our colleague from US has the opposite problem, because the patient in the United States, first of all, consider only chemorad, because this is a cultural approach to this type of. We have to state that in Italy, we are a surgery-oriented country, but every time we offer the patient non-surgical option when non-surgical option is, in our opinion, feasible with good results. Because we cannot, by example, Claudio told about a meeting, IPOS meeting in Seoul, but when I was together with Fernando Diaz in Buenos Aires, attending a tumor board, a simulated tumor board, they discussed about 8 cases, and the introduction was, we have a lot of option, surgical option, TLM, OPHL, supracrical, supratracheal, etc., and among 8 cases, all 8 cases underwent chemorad, and then half of these cases total laryngectomy. At the end of this interesting discussion, I called the attention. Okay, colleague, I agree with you. Chemorad was an option, total laryngectomy another, etc. But out of these 8 cases, in Italy, personally, I could offer to this patient in 7 cases an OPHL, 7, with good, in my opinion, good probability to spare the larynx. Arlene Forestier, look at me, and then, but anyone told me that it's possible to obtain a good radicality with OPHL in these cases. And this is the issue, because in my opinion, we have to reach in our personal tumor board the same level of quality in all these different type of option. Because if we are only able to do OPHL, okay, OPHL to everyone. But if radiation therapist is at the same level, the oncologist at the same level, when is possible, in our opinion, to apply as demonstrated in the lady, friend of my wife, why not? I agree. In this case, we offer the modular approach, meaning starting with a supracrital approach to check directly this possible subglottic extension reaching the cricoid ring, but with the possibility to shift to type 3. In fact, at the end, we carried out an OPHL type 3 and selected the section on the both sides. And here we are, the microsection to be commented by the pathologist.
Yeah, sorry. So first of all, let me say that Ilaria, our radiologist, is a sort of a sniper, because, you know, on this case, we had this kind of surprise. So the tumor was in the, well, basically in the paraglottic space. So this is what we found. You can see, unfortunately, I cannot use the indicator, but you see the violet tissue is the tumor on the slide. And that is what we found. And so the final staging was a PT4A. And it was quite a surprise, even if Ilaria told us that she saw something in the paraglottic space. Okay, yeah. Okay, sorry, good. So I tried with this line to, you know, to mark the limits of the tumor. Okay, and you can see on the right, it's an image. I'm sorry that the quality probably is not the better possible, but you can see the tumor in the fatty tissue, in the fibrous fatty tissue. And so our job from the pathological point of view was quite easy in this case, but it completely changed the staging, the clinical staging. Okay. Here you see in the yellow circle, it's missing a piece of the tissue, but it is exactly where the tumor was. You see it in the picture on the right. Okay. So it was posed. Okay. Good. And this is a picture of of the tissue we obtained. It is basically all you see in the yellow circle. It is all cancer invading the extralaryngeal space. So from our point of view, it was quite easy.
20 maggio 2019. Paziente sottoposto a intervento di OPHL tipo 3A più SND sinistro secondo quarto livello più sesto livello. Buongiorno.
Buongiorno.
Come si chiama?
Ralfio Losano.
Quanti anni ha?
69.
Quando è stato operato?
Il 24/5/2018.
Che lavoro fa o faceva?
Oggi sono pensionato, prima facevo l'assicuratore.
Ha difficoltà a bere?
No,
A mangiare?
no,
Riesce a fare 2 piani di scale a piedi senza fermarsi?
sì,
È stato ricoverato negli ultimi 6 mesi per problemi polmonari?
no.
Prego, beva pure il bicchiere d'acqua.
Okay, as you can learn by this case that sometimes we can have a jump of stage. Rogerio, Claudio, André agree with me that not in every cases we have a natural history so so correct. Sometimes we have a bulky tumor in a place, but with the progression of tumor out of larynx, and this is really dangerous. This means that the workup is really important in defining these cases, and for this reason. Rogerio published this interesting book based on clinical cases, because this is the practical demonstration of the utility to learn from every case we treat and every case we follow. Okay? Another case.
A female, 54.
Excuse me, this case, in my opinion, is important to understand the concept of transgression or not of the magic plane matched with the motility of the arytenoid. Okay?
So a female, 54 years old, smoker, good performance status. 7 years ago, she was submitted to a CO2 laser rhycodectomy in another institution. She arrived to our attention with this endoscopy. So, a bulky lesion that involved both vocal cord. There is, the left vocal cord is fixed. There is a transgression of the tumor, and both arytenoid are mobile. It's a very challenging case. It's a young female.
We can't hear you.
Arytenoid is not in agreement with the fixity of the arytenoid, because the arytenoid is not fixed. In this case, we have a clinical transgression of the magic plane, meaning that the tumor on the left transgress and involves the posterior paraglottic space, but without impairing the motion of the arytenoid. This means that in the natural history of this tumor is starting to involve the posterior paraglottic space, but not invading the whole posterior paraglottic space, because in this case, the arytenoid was not fixed. These are the information we addressed to our pathologist in order to check, radiologist, to check the real extension.
Okay, this patient underwent MR, and as you can see, there are some motion artifacts because the cooperation was not so good. However, so the quality of the imaging was not optimal. However, what can we see? On the glottic plane, there is a full thickness lesion at the level of right true vocal cords that involves the anterior commissure, and it spreads in contralateral true vocal cord. The inferior paraglottic spaces is involved on both sides, but major on the right side, where it is extend beyond the magic plane here. And what about cartilages? As you can see, the arytenoid are dark because of a sclerotic aspect that is, in this case, is aspecific. And the lesion, especially on the right side, is very close to the inner cortex of the thyroid cartilage. But as you can see, there are no abnormal alteration of the signal intensity. Okay, now we have to check if the lesion had a supraglottic extension. As you can see, the preepiglottic space is spared, as well as the superior paraglottic space with a small laryngocele on the right side. What about subglottic extension? As you can see here on coronal plane, I estimate the vertical extension equal to 11 millimeters, more or less, so with an initial subglottic spread. But the most important aspect in these pictures is at that level. Here we have the thyroid cartilage, here the cricoid, and this is a very important point, the so-called posterior cricothyroid space. And as you can see, abnormal tumoral signal alteration is present on coronal and axial plane. It is very important that to analyze this space because it represents one of the pathway of extralaryngeal spread that in this case I couldn't identify. Okay, there is no image referable to Delphian, pathological Delphian node, nor enlarged neck nodes. Okay.
Okay, as demonstrated by Ilaria, in this case, we have naturally a tumor that technically is 83 because it's inside of larynx, but currently is a small PT4 because it's exiting in the cricothyroid space anteriorly to the posterior paraglottic space, but immediately anteriorly. Therefore, this means that for this reason doesn't impact on the motion of the arytenoid. And here we are. We have in front a case in the middle of the river between a T3 and T4, but we have to consider possibly a T4. And our option were a supracricoid laryngectomy and resection of arytenoid, but in my opinion not safe because the tumor, as demonstrated by Ilaria, is here between thyroid and cricoid. In this way, leaving the cricoid is dangerous. Therefore,
can't hear you.
But in young women with this characteristic, if we apply total laryngectomy, it's better to suggest before a chemoradiation. I don't know, the total score was 0, meaning probably a good probability to spare the larynx. Therefore, if we suggest the patient an OPHL, we have to be really sure to reach the radicality, because otherwise it's better to suggest chemoradiation. I don't know if you have some suggestion about this therapeutic option.
Rogério, what do you suggest?
Well, I think it's not possible to assure the patient that a total laryngectomy would be avoided. So I think that chemoradiation therapy would be a good option. I think we'll have to talk with her. The type 2A, I think it would not be feasible, but type 3A would. however, with some risk of converting into a total laryngectomy. So I will talk to the patient about that.
Yes. This was also our issue, and I have to confess you that the reason why I suggested a OPHL type 3A was this minimum respiratory space, because during chemo-red, in my opinion, this patient has problem with breathing. This means that probably our radiation oncologist requires a tracheostomy before, etc., etc. I was quite confident about the possibility to reach the radicality. Therefore, the patient approved the schedule of a type 3A, and here we are, the intraoperative check by the surgeon. This is the thyroid lamina, this is the cricoid, this is the cricothyroid space, and this is the tumor. This means that the tumor is exiting the larynx without be out of larynx. And in this way, resecting here with the supratracheal laryngectomy, we can reach a good radicality. If you want to comment, Davide or Elena.
Yeah, sure. So this picture points the attention on two main aspects of this tumor. One, with you see the black arrows, is that it clearly invades the inferior paraglottic space. It goes close to the cartilage, but we did not see any invasion of the cartilage. And if you see on the bottom, the red line highlights that the tumor invades the cricothyroid space, but it stays inside the larynx. So we did not see any invasion, any extra laryngeal spread. So that's why this tumor was a PT3 in the end. Out of note, we also found a micrometastasis, and so it was also an N positive tumor.
Of course, as mentioned by Claudio, it's mandatory in these cases to dissect the level 6. This patient had the one single lymph node without extracapsular spread at the level 6. Pre-margins, no lymphovascular invasion, no perineural invasion. In this case, as you can see here, this is the cricoid, this is the thyroid lamina, and without applying a type 3 supratracheal laryngectomy, we cannot reach a good radicality here with the supracricoid. Therefore, the patient wasn't addressed. This is the minimum metastasis without extracapsular spread. It's not possible to see to be seen by the radiologist. And I have here the follow-up. Show you.
Buongiorno. 25 settembre 2019, paziente sottoposto ad intervento di laringe.
Excuse me. No. Excuse me. Emergency.
Subtotale OPHL tipo 3A più CAU destra più svuotamento bilaterale.
No, excuse me.
Come si chiama?
Fedele Teresa.
Quando è stata operata?
Il 7 febbraio 18.
Che lavoro fa o faceva?
Sono operaia.
Ha difficoltà a bere?
Pochissima.
A mangiare?
No.
A fare 2 piani di scale senza fermarsi?
Un pochino.
È stata ricoverata in ospedale per problemi polmonari negli ultimi 6 mesi?
No.
Beva pure il bicchiere d'acqua.
Gianni, can I make a quick comment?
Yes, of course.
That's the reason I think the sophistication that you demonstrated here in the whole, not only tumor board, But I like to add an expression to that, because tumor board usually is, at least what we have here in Brazil, at what we saw in the United States and in Europe, it's a tumor board for decisions on treatment. And I think you stepped a step forward, which means you involve, we have radiologists, we have obviously other professionals, but I think you reached a different level on the tumor board, which is a very sophisticated combination of diagnostic tools to properly stage the patient. And going back to the paper by Henry Hoffman of 2006, when he showed very clearly that the chemoradiation therapy, the so-called organ preservation, non-surgical organ preservation in the United States was over-indicated many times for truly PT4 laryngeal cancers. I think that at that time, if they would have had this kind of diagnostic sophistication that you are presented right now, probably they would not have indicated chemoradiation instead of a total laryngectomy. Total laryngectomy is fine. It's a very nice operation. Okay, we are trying to keep the patient off the tracheostomy, but it's a very acceptable operation and we still use it in many patients. So I like to publicly congratulate you on that initiative that I think it must be widespread. We don't have any North American participants in this panel, but we should, because they would learn a lot about how to diagnose so-called intermediately advanced laryngeal cancer.
Yes, I agree with you, and I would like to express my experience because together with some Italian very skilled radiation oncologists, we would like to help them to select the right patient for ChemoRed, because in my opinion, when the patient is well studied, the possibility to reach a good result with ChemoRed is high. It's really similar to OPHL. And then, in my opinion, the choice is oriented by the patient, the age of the patient, the distance between the patient and the center where to deliver radiation therapy every day, etc., etc. But today, in some cases, we are able to see some indication to ChemoRed in clearly T4 patient, but by example, small PT4, as demonstrated in these cases. In these cases, when we have a tumor not inside the cartilage, but over the cartilage, the risk to have a recurrence is high, and in this case also a level 6 lymph node, positive lymph nodes, etc., etc. In this way, I am more confident with my surgery because I developed experience in this field. But my experience can be shared with our non-surgical colleague in order to allow them to know the real step of the natural history of this tumor. I agree with you. We need an important international study without choosing one option instead of the other, but with the same workup. With the same workup, the step forward is to apply biological information, biomolecular information, genetical information on a type of cancer instead of the other, but the workup should be the same. I agree perfectly with André choosing this topic, because this topic is fundamental in this way, in this moment.
Jenny, I would like to thank you but unfortunately we have run out of time. And I think it's very nice, enthusiastic. Maybe we should continue in another web meeting, because we have 2 hours of presentation. So if someone has any the last questions. No more. Just one question, please. And
Yes.
how many total laryngectomy do you perform per year in your department?
Today more, and are increasing. Why? Because is increasing cases treated by TLM in uncorrect after uncorrect workup, meaning
So-
that we jump the option of OPHL, because this means that 5-6 years ago, no more than 15 total laryngectomy a year. Today a double, 30 total laryngectomy a year. But the patient operated yesterday was treated 2 times, but by TLM, then radiation therapy, then yesterday total laryngectomy.
Yes.
So most of total laryngectomy are salvaged for chemoradiation therapy or for surgical?
In Italy for surgical approach, and then radiation therapy. The worst condition, a couple of laser and then radiation therapy, and then it's impossible to save this larynx.
Okay. Thank you. Dr. Antônio Gonçalves, algum comentário?
No, thank you. Nice presentation, nice discussion. Congratulations for all.
Thank you, Antonio. It's a pleasure and honor for us.
It's my pleasure.
Also Erika, and also Ilaria, Davide, and Elena.
Thank you very much.
Thank you very much.
A great pleasure, Succo. Thank you for all of you. Nice work. Nice work.
Thank you to you.
Thank
Bye
you.
bye, brother.
Time.
Bye.
Thank you,
Bye
brother.
bye.
Un abbraccio.